It's with great pleasure that I introduce my colleague Nick Trott, who's a dietitian that works here with us in Sheffield. He has extensive experience in managing patients with celiac disease, gluten ataxia, non-celiac wheat sensitivity and a low FODMAP diet. And he's going to talk to us today about digital platforms in gastroenterology.
Thanks, Mel. Wonderful to be here in real life with so many of you today. As Mel was saying, I'm Nick. I'm one of the gastroenterology dietitians here. So I'm going to do a brief talk about digital platforms in gastroenterology. And I'm going to cover some current examples, if you like, pardon the pun, what's happening. I apologize for that. National webinar on patients with newly diagnosed celiac disease. So that's a platform that we're developing here in Sheffield. It's an ongoing project, as well as looking for some of the benefits and challenges for digital platforms. So I wanted to start with a general picture about what's been happening over the last 19 months during the pandemic, and I'm sure some of us can relate to some of these. So in primary care now, 99% of GPs are able to do video consultations. There's been 11,000 tablets used in care homes. About 40,000 laptops are available to NHS staff. And perhaps the most significant one, certainly for me, is 1.2 million people can now use MS Teams. Last year, over 9 months, there was 24 million MS Teams meetings, and I personally feel like I attended half of those last year. So I think practice has changed over the last 19 months. Now, that's also reflected in gastroenterology. So there is this package of options put together called the GDP, the Digital Playbook in gastroenterology. Now, I apologize, this is a slightly busy slide, but I do want to give you an overview of the projects that are going on out there. Things like remote consultations, you're going to be hearing from Vicky next after my talk. But I did want to focus on two specific elements here. IBD care remote app, as well as looking at a smartphone for the treatment of IBS with a low FODMAP approach, just to give you a flavor of some of the things that are going on. So my IBD care app has been developed over the last sort of 2 years, and you can, as a patient, you can access it free. You can learn more about your condition. You can track signs of your symptoms and see if you're having a flare. You can build positive habits through lectures within the app, and then you can manage and stay in touch with your IBD care in secondary care as well. So the app itself does have about 16 multiple-day courses and about 50 bite-sized courses within the app. And basically what they've done is collected loads of patient-reported outcome measures, and patients have reported increase in physical activity, improved social connectivity, and positive impacts on mental health. And about 32% noticed a reduction in appointments, including face-to-face and telephone calls, as well as about 1.7 fewer appointments per patient. So genuine clinical benefit to the service that's employed it, as well as benefit to the patients. And then here are some quotes from patients themselves. So about 87% saying that it impacted their mental health and well-being in a good way, as well as improving exercise. And it was directed to people with chronic health conditions like IBD, so specified towards them, as well as during shielding, increasing that connectivity. So there was some good patient feedback about the app. Now, I do want to move on to an app that's used for the delivery of the low FODMAP for patients with IBS, but obviously as a dietitian in the area, I really want to hammer this home before I go any further. So we know the most effective clinical way to deliver the low FODMAP approach and intervention is through dietetic intervention. All the studies that so benefit, all the meta-analysis that you've seen out there from benefit of the low FODMAP diet are through dietetic delivery. And this study from Takaltan in 2019 illustrates this. Essentially, if you saw a dietitian, you were much more likely to achieve the relevant FODMAP restriction of less than 12 grams of FODMAPs a day. So leaflet delivery, app delivery, it's a bit of a moot point. I would say the evidence we have is for dietitians doing this. However, there's this app that's produced by Food Maestro, and in combination with a dietitian, it can lead patients through the 3 stages: restriction, reintroduction, and then personalization, as well as being able to barcode scan products and record symptoms and things like that. And there has been one feasibility RCT in about 51 patients that looked at retention, ease of inflammation, and I think what I draw your attention to is adequate symptom relief with the IBS SSS. So obviously, it was much better with a dietitian, but the app was pretty good, and a leaflet was less effective. So the authors in this study said there was a preliminary outcome that maybe an app would be useful as a self-directed therapy in of itself, but we need way more research. And again, as a dietitian who's delivered this approach for many years now, I would say patient selection is crucial here. Patients need to actually have IBS defined, so we need to eliminate those alarm factors potentially. And in my humble opinion, anyone using the low FODMAP approach should be screened for restrictive eating behaviors and disordered eating behaviors prior to the implementation of this approach. It can be troublesome, and you'll be hearing more about that from my friend and colleague Will Holland in due course this afternoon. But I think there's some interesting data here. So moving on to our project here locally in Sheffield. So this is a national webinar. There are some brilliant webinars out there already, but this is a national webinar for patients newly diagnosed with celiac disease. And we really wanted to develop this because nationally and internationally, there's some data that maybe 30% of patients with celiac disease on diagnosis have no input from a dietitian. And both national guidance in America and around the world and here, like NICE guidelines, suggest that dietitians are crucial at diagnosis for education of patients. Maybe about 40% in that international study were not adhering to the gluten-free diet. And studies that we've done locally in Sheffield, we did a national survey last year demonstrating that about 50% of gastroenterology departments do not have a specific pathway for celiac disease management. So we wanted to try and address some of this and standardize care by producing a national webinar that looked at some of the medical background for patients as well as leading people through the gluten-free approach. Myself, my colleague, my wonderful friend and colleague Christian Costes-Batal from Bradford Hospitals, as well as Prof. Sanders have developed this webinar. So the idea of this is we use user-friendly animation. So this is one of them trying to explain villus atrophy and the autoimmune process to people with celiac disease. So you have gluten phagocytosing into the lamina propria, and then you have these lymphocyte response eventually leading to inflammation and villus atrophy. So using these user-friendly information, we can sort of demonstrate to patients what's going on. And in my experience, explaining the condition is really important in this cohort of patients. Again, a busy slide, I'm sorry, but myself and Christian then lead patients through a specific sort of pathway through the gluten-free approach. So what is gluten, how we define a gluten-free diet, which is very important, foods to include, as well as label reading, navigating social situations, which is so important to this cohort of patients. We need to be very specific about, it's not just knowledge, it's how they manage social situations, as well as limiting cross-contamination, the availability of prescription where that's a possibility, as well as Celiac UK resources. So we walk people through this step by step in this webinar. And I think the unique thing about this webinar is its functionality, the website. We're able to safely collect patient data. So anywhere, any trust accessing this will be able to go back in and see who's watched the webinar, how have they gone through it. And then we'll also be collecting initially quality of life data like EQ5D as a baseline to aid research and the quality of the app going forward, the webinar going forward, as well as monitoring baseline symptom burden. And I think what's really useful for us as dietitian, educational attainment and comprehension. So we'll be asking pre and post questions about patients. Can they identify foods that are naturally gluten-free? How are they doing with labels? So very practical data that we can collect. I think that will aid some of the research in this area. And this is all done in a very safe, protected website that's at the bottom of your screens there. It's not live yet, but hopefully it will be very soon. And equally, I just wanted to touch on some of the challenges as well. There are quite a few, I think, with digital platforms, but I just wanted to highlight two that I think are particularly relevant for the NHS. So this concept of interoperability, and I think we've all had experience of this in the NHS over the years, where you develop a package or there's a bit of IT software that then won't speak to other versions of IT software. So I think at any development with a digital package from stage one, it needs to be able to speak to different clinicians, to the patients, as well as other IT services and other trusts. So this is something that we've tried to carefully build into our package. And the other thing, obviously, is the digital divide. This is an ongoing issue. I think we've seen this acutely during the pandemic in terms of educational problems as well, but we see this in healthcare. Even though there's potentially 90% coverage in the UK with mobile phones these days, there's still a lot of digital illiteracy, and patients do need to be walked through some of these packages, and I think that needs to be built in to any digital package. So I think to end on a positive note, my experience of some of these platforms, when they work well, they can improve accessibility, enhance outcomes, and reduce costs. But also from a research perspective, I think we can better collect data, we can recruit and involve patients in patient involvement more. So I'd just like to finish by thanking my colleagues at Sheffield Gastroenterology Department, and thank you for listening. If we've got time, I'm happy to answer any questions.